uh, reversing menopause. And before I go ahead, let me thank Parag for not asking me to give my pearls of wisdom during that session. I would have loved to do that, but nevertheless, here I am talking about reversing menopause. Thank you, Ragini. Okay, so basically this is a very interesting saying by one of the pioneers who is doing a lot of work in infertility, Claude Anderson. Aging is considered as a pacemaker of the female body aging because it drives the aging of multiple organs of the body. So it is so true, because basically it all starts with the ovary, and actually ovary is the leader when we are talking of aging. So life expectancy, as we all know, has increased. And what is interesting to now understand is that when the life expectancy becomes 100 years, it is estimated that most of the girls who are born today are going to live up to that age. So that is going to become a very big burden for the whole world when the entire women population is going to be 100 years. And therefore, the society is facing a considerable challenge in improving the quality of life and longevity of the senior women. And even in India, what we are finding is that the expectancy has now grown up to 69.6 years. And I remember when we started talking about life expectancy in India in the first guideline that we issued in the Indian Menopause Society, it was 62 years at that time. So we have also grown considerably over these years. And that is quite heartening to see, because basically it means that the healthcare of the Indian subcontinent has definitely improved. And the IMS guidelines also say that the mean estimated age of menopause is 46 years in India, which is of course lower than the Caucasians. We all know our own studies in the Indian Menopause Society done by Maninder and et al. Have also shown the same thing as the other very well quoted or well cited study from the fertility segment, which is the comparison between Spain and Indian women. So therefore, women are spending more than 20 years in their postmenopausal age, even in India. And hence, we now understand why osteoporotic fractures are occurring 10 to 20 years earlier in the Indians. Why is first myocardial attack occurring 4.4% of Asian women at a younger age as compared to the Europeans? Type 2 diabetes appears also at a younger age. Breast cancer incidence peaks before age 50, and cervical cancer is also always rising. So therefore, all these diseases, all the patterns of disease are enhanced in India. Why? Because our menopause is ahead of the other countries in the world. And hence, basically, we also have to understand that 1% of women will experience ovarian failure before the age of 40 and will have a post-menopause, premature menopause below 30 if in about 0.1%. And that is exactly what we are seeing in our infertility clinics when we are finding women who are coming to us at age 29, 30 with premature ovarian insufficiency. So we are now today looking at two kinds of patients, those with a normal menopause and those with a premature menopause. And we must understand that premature menopause, according to us, is about the age traditionally considered 40 years, but in India it may even be 36 years or 38 years. And early menopause is basically the time span between spontaneous and iatrogenic menopause, occurring between the age 40 years and expected typical age of menopause for that population. So basically, if we are saying that we are aging a little earlier than the West, then anything happening earlier than that is early menopause. What about failure and insufficiency? Let us just understand that there is an inherent difference between failure and insufficiency. When you are talking about insufficiency, the FSH values is around 25. And when it is failure, the FSH value rises to about 40 IU, which means nothing can be done about this woman. While at 25, you may think that you may be able to help this woman somehow or the other. So what then is the difference between premature ovarian insufficiency and true menopause? Normal menopause is irreversible, while 50% of women with premature ovarian insufficiency will experience intermittent ovarian function, and they may have their periods occasionally. So they will be producing estrogen intermittently, and they may be ovulating off and on. That is why pregnancies are reported in 5 to 10% of these cases naturally as well. This is something that we need to understand and remember always when we are treating patients with premature ovarian insufficiency. So hence, then, ovarian aging, what does it mean to us? What does menopause mean to us? It means that either there are going to be no oocytes when the patient is trying to have a pregnancy, she still hasn't had a pregnancy, and she comes to us with infertility, or she has no hormones and she has multiple morbidities and hormone deficiency. So basically, this is how the women are going to present to us. And the medical management that we have always been trying to give to them is basically the mainstay is MHT, which is the hormone therapy. But we also have been giving herbs and plant estrogens. And over a period of time, there have been lots and lots of developments in all these areas. And we find that we have now many subtypes of drugs and medication, which is now being practiced and given to women who are coming to us with premature aging or premature menopause. So how can we halt aging? Now we have to understand that there are two kinds, and I think Sheila mentioned this in her last lecture, or someone did mention. No, Jyoti did. Jyoti Shah was saying that she would still want to be 72. So there is something called superficial aging, where we are worried about our phenotype, where we are worried about our looks, and there is aging of all systems, which is the true aging. That means that we are having aging of all the systems within us. So there is a difference here and here. And that is what we have to understand when we are treating menopause and when we are talking of reversing aging. And look at this. This is the phenotype that changes. This is what is bothering us, because this Zeenat Aman has actually become what she is today. But she is very, very graceful and she looks beautiful even when she is like that. Yet her phenotype has changed, and many may not recognize her as the seductive actress that she was many years ago. And so superficial aging comes with weight gain, wrinkles and sagging skin, gray hair and baldness, laxity of the vagina and other parts of the reproductive system, prolapse, etc. So the result is a distorted body image and loss of self-esteem for many women who are so conscious of their self and their being that they are very disturbed when they have something like that. And I think that is what Ragini has taken up as her passion, and she is looking after the aesthetics of and cosmetology of the mature woman. So, but what about the aging of systems? That is what we are worried about in the Indian Menopause Society. And this is the aging that we should be talking about. And when we talk of reversing menopause, we are actually wanting to do this. We want to reverse cancer, Alzheimer's, heart disease, diabetes, dementia, and many other diseases like that. So all kinds of disorders which the woman is going to have, we need to kind of reverse that. So what does the superficial aging entail? It generally or essentially means a makeover. So the goal is to get my feminine figure back, and hence breast lift surgery, body contouring, and of course the bariatric surgery which women resort to. If you want to feel sexy and confident again, so female or feminine rejuvenation is what we are looking at. And if you want to look healthy and refreshed and not haggard, then facial rejuvenation treatments. This is what essentially, when we are looking at superficial aging, this is what it means. But what does it entail when we are looking at the actual aging? So new strategies are now being developed to prolong the reproductive potential. And we have lots of things which are coming up. Oocyte cryopreservation, ovarian tissue cryopreservation, oocyte rejuvenation with PRP, bone marrow stem cells, etc., ovarian activation, and artificial ovary formation. So this is the ultimate now, that you finally form another ovary so that the woman can live again. So here are some of the reports which are actually suggesting autologous bone marrow derived stem cells as well as PRP for rejuvenation of the ovary. So the first novel use of follicular pool to postpone menopause was developed by Anderson, as you can see here, Claus Anderson. And what they did was that they cryopreserved the ovarian tissue, looked at the follicles, and then they cryopreserved them. And finally, you isolate the ovarian cortical tissue, or you isolate the follicles and freeze them. And then you do an auto transplant, not at the same time, but after a couple of years. This was essentially started for Turner syndrome, where you are freezing the ovary at a young age when she has follicles within her ovary, and then using those later on when she's around the time of menopause, say 44 or 46 years, in order that she doesn't age and the rejuvenation can begin again, or actually restoration of her reproductive potential starts again. Such ovaries are generally not capable of producing a baby, but yes, hormones are produced by them and menopause is definitely delayed. So this was one of the first experiments that was started, and actually it was a commentary that appeared in this journal, and that has actually set the ball rolling, and we have so many new methods to now start rejuvenating the ovary. But the advantages and disadvantages of transplantation of ovarian tissue are, the advantages of course are that the cryopreserved tissue can be used for generating pregnancies and postponing menopause. The transplanted hormone treatment probably creates a more physiological steroid environment than the menopause therapy. Oocytes from ovarian tissue, cryopreserved at a younger age, they make healthy embryos, and there is less chance of aneuploidy if we can do that. And transplanted tissue allows spontaneous pregnancies and does not necessarily require an IVF. But of course, the downside of it is that removal and transplantation of ovarian tissue imposes surgical risks. The storage has to be perfect, and the transplanted tissue is more expensive. Individual duration of tissue activity is not foreseen. You cannot say what is true for this one is going to be true for the other one. And like I said, not many pregnancies have been reported with this method. The transplanted hormone therapy cannot be stopped without surgical tissue removal. So if you want it, you don't want it there, you have to again go back and remove it. And the effect of this on menopausal symptoms still needs to be validated and evaluated. And we really do not know what is its effect on osteoporosis, atherosclerosis, and cancer, which we are actually wanting to prevent. So these are just new things which have come up, but definitely is an idea which needs to be substantiated. Ovarian rejuvenation with platelet-rich plasma is something which has become the done thing in the fertility circuits. And we all know that plasma, PRP, is being used for all kinds of tissues and all kinds of areas where we want regeneration. For instance, the dermatologists are using it for hair and baldness, and this is also being used to rejuvenate the ovary. The treatment is just the same, because basically the platelet-derived growth factors are released once you prepare once you activate this plasma, and so all these growth factors actually activate the ovarian germ cell stem line and promote folliculogenesis within the ovary. So this kind of a thing is quite well known, and multiple sessions of PRP are required in order to activate the ovaries in patients who are suffering from premature ovarian insufficiency. Similarly, the bone marrow stem cells have also been used instead of the plasma cells, and this bone marrow is derived from the iliac crest. And over a period of, say, you can see over here, a period of 4 to 6 months is when the periods again begin, because the estrogen levels reach above the 30 picograms per ml that we generally have in the follicular phase. And over a period of 12 months also, the ovaries keep on functioning. Similarly, the size and volume also of the ovary increases over a period of time. This study, which was done in 2016, actually looked at all these factors over a period of 1 year, and they found that during this period, the FSH and LH kept rising, the estradiol kept rising, and the ovarian size became nearly normal. So this was a very encouraging report, and ever since then, lots of centers are reporting bone marrow stem cell transplantation to enhance the ovarian function once again, and maybe even achieve a pregnancy. So what about ovarian activation? This is something new which has come up. And what does this mean? There is a pathway by which the primordial follicles are activated, and this is kept suppressed. Otherwise, all the follicles would keep on getting activated every month. And so we have these suppression factors, and we have these activation factors in the ovary in order to activate the primordial follicles. And there it seems that genetically or because of the environmental factors, these three substances in the ovary are somehow not normal. They get deranged. So there is either too much of activation or there is too much of suppression, giving rise to premature ovarian insufficiency. So what we are doing actually is that through laparoscopic surgery, we do an ovariectomy using minimal amount of electrocautery, and you take out the ovarian cortex and you make bits of the ovarian cortex. You do a histological analysis to see whether there are any residual follicles over there in it or not. And then these fragments are activated by treating them with PTN inhibitor and PI3K activator, the three substances that I talked about. We incubate them for 2 days to activate the dormant follicle. So in other words, it is done in 2 stages. In one stage, you're removing the ovarian cortex, you're activating the follicles, and then you're putting it back or replacing them back into the lady's body. So then after this, they are washed very carefully so that the reagents are washed out, and then they are transplanted beneath the serosa of the fallopian tube. So basically in the mesosalpinx, they are inserted, these small bits are inserted, and then this actually leads to vascularization of these small bits, because you all know that the mesosalpinx is a very vascular tissue, and hence it starts breathing and becomes kind of activated at that point of time because of the reagents that we have also added, and follicles start to grow. So this is what is autotransplantation. We keep on monitoring the growth, and we keep maintaining the LH levels and estrogen so that you can see that they are undergoing some kind of a change. And later on, FSH and HMG and GnRH agonists, just as we give for follicular genesis in IVF cycle, the same thing is given and oocyte retrieval is carried on. The first report was by Zing et al. In 2016, and this was reported in the JCEM. So this method is also now gaining importance, and some people are not doing the activation, they are just transplanting, cutting out the cortex and then transplanting it at the same sitting. So this all started in 2001, when Kutluk or Otke, he is supposed to be the father of ovarian transplant, he first dissected the ovary and introduced it into the forearm of the woman, and saw egg development and normal hormone production. The egg was actually removed and used for IVF and to achieve a pregnancy. This was the first report which happened after transplantation. And now, like I said, in Silber in 2015, again experienced restoration of ovarian function with this method, and reported that almost 7 years to 10.5 years, the ovary kept on functioning after having transplanted it. And 62% of one ovary was only transplanted. Similarly, there have been other reports of hormone function for various years. It may be 2 years or maybe extensive as even 10 years. And what is important for us to understand is that lots of women are actually undergoing this kind of a fertility preservation program all over the world, and they are not all of them using their eggs or the ovarian tissue that has been cryopreserved for them. They don't use it because they sometimes become pregnant of their own, and some of the patients unfortunately also die. So for various reasons, a lot of these women have not used their tissue. And so it is suggested again by Anderson in 2012 that probably these tissues, which have been sort of cryopreserved by these women long time ago, can actually be used later on, and hormones can be generated from this tissue in order to actually restore the patient's hormonal status, or as I said, reverse menopause. And this is the ultimate. This is actually the formation of the artificial ovary, which is also now being tried. And actually, this is being done only in patients who are suffering from cancer. So basically, the ovarian tissue is taken out before the treatment is started, cryopreserved, and then later on, when the woman comes back after being treated completely for cancer, the follicles are isolated, and they are actually enveloped in some kind of a matrix. Let us not go into the detail of that, but that is basically to see that no malignant cells are actually incorporated in that. And because of this encapsulation of the isolated follicles in a 3D matrix, they are then washed, encapsulated and then transplanted into the mesosalpinx, as we were doing for the ovarian cortex. And this is basically one of the new formations of the artificial ovary, which is now being created. But of course, this has a long way to go, and we really do not know how much of cancer cells may be transmitted through this. But yes, it is a step forward in order to form something like an ovary, and actually to be able to reverse menopause, and actually to be able to give some kind of a hormonal function to the woman. So over the years, we have realized that the lifespan has increased. Estrogen has many functions beyond the reproductive tract, and aging takes place first of all in the ovary and hence the reproductive system, thus enabling us to study the process of aging in the reproductive system so that we can help the aging processes in the other systems as well. So very exciting developments have taken place in this, but certain unanswered questions definitely are: what is the effect on the breast and uterus and development of cancer breast and endometrium if we are going to prolong or reverse menopause? How many of us would wish to have their periods continue lifelong? And how long would the effect of the procedure last? These are unanswered questions. And of course, like I said, we do not know what is the effect of these processes on the various systems that we are trying to protect, like osteoporosis, atherosclerosis, and all. Time is going to tell us how these methods are going to help us beyond just producing a baby. So with that, I thank you very much, and I wish you all a very, very happy new year. Thank you so much.